Okay, so the new one, you want the axials?
Yeah, axials are good.
Okay, here you go.
And so, and the way we repeated studies because he wasn't feeling that bad by the surgeons when I talked to them when he had arrived. So, so now, I mean, there's a little bit of free fluid. Those are my arrows. And there is this Roux limb. And you can see that there's a nice swirl. And I'm showing the defect, and I'm showing the vessels going through this hernia as they are tapering in. But you can see now the JJ site now is back in the right of the midline. It was moved out of the midline space, and then the vessels are patent. There's a little bit of edema still. It's improved, but still present. So it's just to remind us that not only do gastric bypass patients get Peterson's hernia or hernias through the Peterson space behind the Roux limb, anyone who gets a Roux configuration is at risk of an internal hernia. So Whipple's procedures, liver transplant with Roux configuration, and gastric bypass patients are the ones that we want to remember. And this is actually a very nice example of this is the whirlpool sign. Whirlpool meaning you should never see bowel that completely surrounds the vessels. See how it's surrounding it? It's like making a complete twist around it. They didn't operate on him. There's a big issue with him because he's got this big mesh. He's got some bowel adhesed to it. They are planning on operative, but not a emergent operation because he's getting better because the bowel has since returned in its normal location.
In this patient, there's almost two whirls. So is one going through the Peterson space, and then a separate one that's just adjacent to it that just happens to be also whirling?
Well, I mean, so some people have what we call the double mushroom. So there's one here and there's one here. The defect is, there's a huge defect.
Oh, gotcha. So it's going to either side of the hole.
Yeah,
space.
Big hole, yeah. Through Pearson space, yeah.
And then earlier you said this was a transplant case. Why did they anastomose it to the? Did you say they anastomose it to like one of the large collaterals, the portal vein?
He had so this is the liver allograft, but he had chronic occlusion of the recipient's portal vein, and he had no portal vein. So the patient itself did not have any portal vein. So when they got the liver allograft, they anastomosed it to a collateral.
That's amazing.
Yes, Ottawa team has a very nice paper on internal hernias. And we actually just published a paper in AJR in internal hernias. Larry Chow from Stanford led that initiative. So that just came out maybe last month or something.
That's great. Okay, I'm gonna share the third case. I'm just gonna pause for a second. Then. Okay, this next case is also from Cookie. So this is a patient with history. You can, Cookie, can you? This is a patient with a history of cervical cancer. Had prior radiation treatment for that, and then came with abdominal pain. Patient had 2 imaging done, very close in interval. I think it was spaced by a week or so, or maybe even less, with sort of progressive symptoms. This is the most recent one. Cookie, do you want me to pull up the older one?
Yeah.
Okay, one second.
It's nice to show on the older one, actually.
Yeah, I'll do that.
Online, but see it better on the old one.
Okay, I'll I'll bring up the axial for the older one. Here it is.
So this is a person with cervical cancer, right? Treated remotely long time ago. You can see her uterus, and she's got some, some radiation changes in her pelvic bones, and she has had, recurrent small bowel obstructions. And this was a CT angiography to evaluate for recurrent small bowel obstructions. And as we come down, somehow I don't see my arrows.
This is the older one. Do you want the newer one that might have your arrows?
I threw a lot of arrows on the old one too, actually. But
oh, you did. I can bring up the other axial that has the like 750 images. I don't know if it's on that one.
You want to put the coronal ones on this one too? Anybody have any ideas what's going on in this patient?
Okay, I'll grab the kernels. Here you go.
So we have this area here.
Amar said NSAID enteropathy. Shwachanda said POD Mets with radiation enteritis. What does POD stand for? Shwachanda? Oh, pouch of Douglas. So, yeah.
So go ahead and now bring our my study that I
Yep.
had.
Here we go. So here is the most recent. Okay. Let's see. This is the. Here, let me give here. I'm not sure if the arrows are going to show up on this one either, but we'll see.
Okay. So you could see that she's now coming emergently in the ER with a bowel obstruction. You could see that there's definitely dilated and there's decompressed terminal ileum here. And you could see that just there are indeed focal web-like strictures in this, but this, if you think about it, this whole small bowel loop is not normal, right? So it's fluid filled, and you can see how thickened that loop. So there are longer segments of wall thickening, and as you come down, even this is an abnormal loop as you come from dilated to thickened loop of bowel. But she has several, so it's several short segment strictures of the small bowel. And that's correct. Whoever said that radiation enteropathy is NSAIDs. It can give NSAIDs. You can argue NSAIDs is possible for short segment strictures and web light, and that's a possibility. But when you start seeing these longer segments of bowel that are not normal, this whole segment is kind of strictured and irregular. And then you put it together with history of recurrent bowel obstructions and long remote where they were doing a lot heavier radiation dose to the pelvic. This is a really good look for radiation enteropathy with multiple segmental strictures. So I didn't pick up on the pouch of Douglas. I know there's a little nodule there, but where are we looking at the Mets? Did I miss Mets?
I can pull up the sagittals if you think that'll help. Here,
she's remote history of cancer. She's not, and I'm talking like over 20 years of cervical cancer. And that's a calcified loose body. Anyway, it's just a nice case to remind us it's not just, Crohn's, it's not just NSAIDs or not, that's also a call for a good radiographics or RSNA exhibit is, strictures, not just Crohn's. I would like something like that. Just for anybody, just having a call out there for anybody interested. Boy, it's a real silent team, I see. Okay.
Yeah, it's I guess Arthi wasn't able to log on, so it's a little bit more quiet than usual. Okay, I'm going to pause my share and then pull up the third case. Okay. All right. Okay, so this is a patient with recurrent UTIs. She gets like 15 or 20 UTIs per year. Okay, Shwashanda said urethral diverticulum with stone. I didn't see a stone. This was a case for my colleague, Akira. I see debris. There's layering signal differences. So I didn't really quite see a stone, but there might be. I don't know. So yes, so it's a urethral diverticulum. I presented this case yesterday to my to our trainees. So with MR, what we're trying to do is, to of course provide the correct diagnosis, and then try to see if we can find the the tail, the opening, the where the diverticulum is, so that we can direct our urology colleagues to the site. So I think in this case, I don't know if it's here, but this was a really great example of what a urethral diverticulum looks like. So we had a brief discussion yesterday with Cookie about sort of how to approach these cases surgically. Cookie, do you want to add a few comments on sort of what we need to be careful of so that patients don't get complications from inappropriate approach?
So the purpose of MRI for urethral diverticulum evaluation is, number one, to confirm urethral location or periurethral glands like a Skene's duct cyst or urethral, because, and then the second one is like Nellie said, to find the neck. So you want to find the origin of the neck of the urethra where they can just go in and excise it. So very important to establish urethral or urethral origin, because a Gartner's duct cyst can somewhat mimic if it's in the anterior wall of vagina. So sagittal images are very important. So Gartner's duct cyst can be certainly drained transvaginally, but if you are diagnosing it as a urethral origin, you never want to go transvag, because you can basically complicate with a fistula, a urethral vaginal fistula, by doing that. So real important to have the urethra, taken care of by urologists, so they can excise the neck and then resect. And then the Gartner's duct cysts are taken care of by GYN, done by vaginal approach.
Awesome. Okay, I'm gonna show you my last case. So this is a patient with history of, there was a question from the audience, Cookie. What is the hypointense structure? Oh, that looks like a stone. Oh, just kidding. That was, let me pull up the old case and see if we can review that hypointense structure. Just 1 second. Go ahead.
I was seeing that too, actually, because I don't know if that's urethra. I didn't see the whole case, but I don't know if it's a very thickened urethra or if that is a big stone.
Okay, let me pull it up. Sorry, I had closed the other case off, so. It is pulling. Okay, and then let me reshare. Okay, so what are we talking about this here? The T2 hypointense. What are we? Oh, this. Okay, so this thing here.
No, keep going lower down.
Going lower down. Okay.
Okay, so if you go in the sagittal, there's a big T2 dark thing. I don't know if that's just a thickened fibrotic urethra right below the.
Like here?
Yeah, that big thing.
Oh, gotcha. Okay. So this thing, let me see if I can do here. So this, and then co-localize it maybe to on this coronal, this thing here, this here. I don't,
Yeah,
it looks to me like a thickened, like a scarring fibrosis rather than a stone. I don't know.
Yeah.
What do you think?
Yeah, I agree with that.
Okay. Okay. All right. So okay, great. So let me, I'm going to go to our next case. Okay. So this one just, this patient with history of heart transplant came in with abdominal pain. This is just something to be, it's a pitfall. So there's this hypotense structure here, posterior to the right diaphragmatic crura, which is anterior. And so, I know we had presented a case on the left side in the past, which was a ganglion. But on the right side, we can see this, and this is, what do you guys think this is? I can show you the coronal. Yeah, so Amar and Chishwanda said Cisterna chyli. Yeah, so on this, I think you can appreciate the orientation a little bit better on the coronal. It's elongated sort of along that tract, and so that's a Cisterna chyli. So just be careful, because I think it can be a pitfall for things like a lymph node, and it's hypodense, so we might confuse it for something like a metastatic lymph node, and it's not. It's just a normal anatomic structure. Okay, so I think Amar said he had a case, so I'm going to stop share so that he can share.
Sure. Am I audible?
Yes.
Okay. Let's. So this lady had a bowel resection for a graft versus host disease a few years ago, and now she has a ileostomy, and she's presenting with obstruction. CT, which was 3 months ago, that was normal. I'll go through the images. It's more like a consult rather than, I don't know the diagnosis yet, but I'll get to know it soon. I'll pull up the coronal. So the action, okay, I thought, okay, there's small bowel feces sign, there's obstruction. The site of obstruction is probably at the level of the stoma. But on the coronal, that's where the finding gets a bit interesting.
Yeah, that also is something that happens, is that there's a torsion of the ileostomy as it comes out. So
yeah, that's what we thought, and I wanted the group's opinion. Like, is it that common? Because it's the first time I'm seeing, and there's only one AJR paper which talks about a single case, and I couldn't get enough literature, so we did give that diagnosis. And the other thought was probably, is there a adhesion here which is causing this acute angulation? But the coronal picture was quite interesting, so I just wanted to share it with you.
I've seen it several times. They put a pigtail catheter in them and let it, decompress on it. So they put a pigtail catheter, and that's in the ileostomy, and then sometimes it straightens it out by itself. Sometimes they have to go in, but sometimes it's just a pigtail catheter to drain it.
Right, just like a sigmoid volvulus. Okay, so yeah, that was my case. We've given with that. The patient has not responded. Like, they tried to put in a Foley. He's not. His obstruction is not resolved. They were planning for an operation. I'll let the group know in the next week maybe what this ended up being.
Awesome. I have another case if others don't have cases to show.
Datan?
Sure.
Yes. Who is that?
I have a case that I could show. It's not that cool, but I have one anyway. Let me see if I can. Okay. I'm like somewhat Zoom inept, so I'm going to try to. Okay, So this is a case that is a recent case of an older lady who had abdominal pain. And I'm going to start with the CT. And what we see on the CT is just multiple hepatic calcifications, both lobes.
The calcifications are, they're kind of fine.
Yeah. But, you know, based on this, I don't know if it's questionable whether she has any pre-existing liver disease or, you know, chronic liver disease, but like a background of that.
Can you scroll down? It looks like there's peritoneal thickening too.
The colon doesn't look too happy either. The ascending colon.
Yeah. Well, I'm showing the pelvis because there was question of whether, you know, could these be like, you know, mets from ovarian or something that's causing these hepatic calcifications. That was one of the thoughts. So she went on to get additional imaging, one of which was an ultrasound. And on the, I'm not going to show the ultrasound because it actually has some information on it suggesting the date of the study, but lesions in the liver were described as targetoid. So she proceeded to MR, which I'm going to selectively pull up some sequences as we go along. But this was the T1 appearance of the liver. So just a lot of kind of diffuse nodules, several of which are intermediate to bright. And on the T2, let me make sure I pull this up without. Overall, I don't know. I mean, these nodules or lesions are overall just somewhat less discernible, less discrete on the T2.
Post contrast and then diffusion, please.
Okay. So I do have I thought this was the most telling post-con, but I can show an earlier phase, but this was a delayed post-con. So it looks like they basically have some rim enhancement. Innumerable lesions. Dilated IVC as well, and hepatic veins are kind of plump too. And on restriction, it looks like just a lot of restricted diffusion goes along with this.
Yeah, I like somebody wrote breast mets. Candida is weird. You know, some lymphomas, small cell lymphomas.
Yeah. So some additional information on this patient was that their AST/ALT were pretty high, kind of close to about 1,000. And they also, I'm not sure why they even drew this, but they had a CA-125 elevation as well. I don't know if that changes anything.
So does the patient have a, you know, papillary serous primary?
Well, we didn't see one. So we were just kind of stumped by it. I don't know if she could have one that's just not seen, but they did a random liver biopsy, so I do know what this is. Which, again, it doesn't. I mean, I'm sure it fits in retrospect, but probably not all of that information. There was no. I mean, the pelvis looked fine except for fluid and maybe some ugly bowel. So on path, none of this ended up being cancer. It's actually all, I'm looking at the path report and it says necrotic nodules, granulomatous inflammation, and possible acetaminophen-induced liver injury. So drug-induced liver injury.
Oh my goodness.
And some component of congestive hepatopathy also. But this was all, I think, you know, again, this is, I mean, and the sample was good. Like, it's not like, you know, the sample wasn't adequate. So this is definitely not a cancer, which was a little confusing to me. Pretty much it says drug-induced liver injury.
Have you seen that before, Kiki?
I've not seen Tyler. I'd like to, you need to send me the MRN. I need to review it, the path. I mean, it's granulomatous reaction. Is that what they said?
It says necrotic nodules surrounded by granulomatous inflammation.
Yeah. Okay. That's, I mean, I can show you a very similar, that's why I said Canada, very similar with granulomatous, because we had a very similar case on CT with extensive calcifications in a patient with lymphoma, and the biopsy, I made them, you know, pass look it twice, and they kept calling it granulomatous, and they're hypothesizing, you know, what the source is. I mean, now they're hypothesizing, you know, drug induced, but it could be anything that's causing the granulomatous. It's interesting.
I forgot to show this, I'm sorry, I forgot to show this sequence, and there was a fair amount of dropout of the background liver on in phase. So, but yeah, none of this ended up being cancer or malignancy.
Great case. Oh my gosh.
Yeah.
Okay,
So does the patient have a remote history of cancer? Older?
She is older. I was trying to dig up a history of cancer. I couldn't find one. She doesn't have her uterus, and I couldn't even find the reason for that either. But
Okay.
yeah, but we'll take a look at it.
It's a great case.
Yeah, that one's interesting because in one part of the pathology report, it says suggestive of drug-induced liver injury, and then it says comment, and then it says pattern of injury versus infectious etiology.
Yeah, I mean, it's granulomatous, so they try to figure out. I mean, I have literally the same case, and they kept calling it granulomas. I'm like, well, granulomas from what? Is it sarcoid? Is it TB? Is it a bug? And they wouldn't come through. You know, they wouldn't come back on it. So it just kept the diagnosis is granulomatous is what we need to figure out as a source. I don't know, but it's good. It's a nice case.
And Amar said when the liver enzymes are really high like this, drug injury would be a good differential to add as well.
And that's what all the notes, the clinical notes were saying too. Like the transaminitis was high enough for that.
What a great case. Okay, I have a case to show. So this is a patient with a known condition, which I'm not going to share because that'll give away the answer. So what do you guys think is causing all of the vascular? What's a differential consideration?
Can you hide all the measurements?
I cannot. Actually, I
Oh.
can. Let me do that. Let me pause share so that when I tab through the measurements, how about that? So which condition can sort of cause these vascular findings in the abdomen? So the aorta is
it a cork to the abdominal aorta?
The aorta is uber tiny. What's that?
Just for a short segment, like a cork to the abdominal aorta.
Yeah, and there's that, like, if you look at the SM, let me pull up the satchel again. It's high-grade stenosis at the celiac, and it's like almost essentially obliterated, and SMA. The patient also has an accessory vessel here that's sort of kind of like serving as a collateral right there, because the SMA and celiac axis are essentially, I mean, you just have this short segment high-grade stenosis. Okay, so we've got tons of people texting in. So Shoshwanda said small aortic syndrome. You'll have to tell me what that is. And then Omar said mid aortic syndrome. And so you'll have to explain to me what's the difference between the small and the mid aortic syndrome. Okay, so this is, what else? Shoshwanda or Omar, what's the mid-aortic syndrome? Can you, I don't know what that is. Can you share that? Educate us. Or Shoshwanda, if you can.
Hey, can you hear me?
Yes. Is this
Hey,
Omar?
yeah, this is Omar.
Oh, awesome.
Yeah, so it's the syndrome that affects young adults and children, usually male, with long segment mid-aortic narrowing. Usually associated with the triads with hypertension, claudication, and renal failure. And I think the renal failure part and hypertension comes from the stenotic segment involving the origins of the renal arteries.
Oh, gotcha. So it, so here I think the renal, there was ectasia. Sorry, go ahead.
So I don't know if this patient fits that demographic.
I think it's a female.
It's female, okay.
So this patient, so the other thing to consider in addition to mid-aortic syndrome, which this patient had, is NF1. So patients with NF1, they can get vascular manifestation, which includes both stenosis and aneurysm. So this patient has the stenosis of the aorta. There's also a high-grade stenosis of the celiac and SMA, and then there's ectasia of the ostium of the renal arteries. So it's a case of NF1. So she came in because of abdominal pain, so they were worried about SMA syndrome.
Does she have a angio on record, Nellie?
An angiogram? Yeah. I think this is it, isn't it?
No, I'm at a standard conventional.
I'm gonna pause share so I can look at. She, I'll follow up with you. She does actually. Okay, let me see if I can pull it up for you.
I don't know if you can get it without the names, but.
Yeah, I've paused my share, so hopefully, she has a renal angiogram, but this was remote though. And then she has, so it's a renal angiogram. I think that should have that information.
Yeah.
So okay, it's in the archive, so it's pulling. Okay, well, oh, here it is. Wow, that was so fast. Okay, where is it? Here it is. Okay, so let me share my screen again. Okay, resume share. Okay, here it is. This is from a while back, so this is not a recent, but the findings are still present, it looks like.
So weird. I love it.
Okay, so that's it for me. Anyone else have any cases?
I sent you a case by just by email, Nellie, and if you could pull it up really quick. I don't know how to share it on my screen.
Oh, okay. I can pull it up. Let me see. And then does anyone else have any cases while I pull up this other case? Okay, this is dynamic cookie. Let me see. Oh, here it is. Oh, this is a good one. Okay, all right. Let me see if I can pull it up. Hopefully I don't have to. It'll all be not archived. Okay. All right. So, okay. Let me pull this up. Okay, there it is. Share screen. So there's a bunch of studies. I'll just pull up the most recent one. Okay.
Yeah, you can put the one from today, and then there's one in April, like 2017. There's one in 2017.
You want the 2017 first?
Yeah, 2017 first would be good, just to show the.
Okay. Okay, so then I'll pull up the one from. So we're trying not to mention dates if possible, but I will share my screen now. Okay, so this is from a few years ago. Let me see. I think you should be able to control my screen, but let me just make sure you can. Okay, go ahead. There it is. This is for a few years ago, and let me know if you want the more recent ones later.
So you could see that there's extensive lymphadenopathy in this older patient and a big spleen. And can you show me the axials?
Yes. Okay, it's coming. Here it is. This is the thin, but
Yeah.
that works.
Okay, diagnosis, anyone? Quick. Yeah, okay, lymphoma. And the older person, you want to think what? CLL, great. Okay, so let's go to the most recent one.
Okay, it's coming. Okay, this is the most recent one is right here.
Okay, so I am scrolling down and you could see, you know, pretty good response. But can anybody tell me what's going on in this lymph node or this lymph node or that lymph node? That lymph node. This lymph node, what's going on here? Anyone?
There's fatty proliferation at the hilum. I don't know if that's a term, but if that's what you're trying to point out.
Yeah, so why is there macroscopic fat? And we see lymphoma all the time. Why? And we don't see macroscopic fat in these.
Right.
So this is an interesting phenomenon. It is macroscopic fat. Basically that it's not a metaplasia, but it basically enlargement when the tumoral nodes decrease, the fat increase and becomes macroscopic fat. But it's particularly in Ibrutinib, which is the drug for CLL. I mean, it used to be with rituximab. They still give rituximab. I've seen it with a couple of rituximab, but I've seen it several times with Ibrutinib as the chemotherapy agent of this macroscopic fat deposition. And it's a feature of good response where the tumoral component of the lymph nodes decrease and the macroscopic fat increases.
Excellent. I was not aware. That's quite an, yeah, with these newer chemotherapeutic drugs, there are so many of these response-related findings that you need to be aware of.
So I am giving a grand rounds for Mayo Clinic, which is actually free for anybody who wants to register for it. It's Thursday, 8 o'clock Arizona time. I don't know. We can copy and paste the link, I guess, here.
Sure, that would be great.
And it's all on adverse effects of the abdomen with targeted therapy. Let me see if I can find it here.
This Thursday?
This Thursday, as in after tomorrow. It was tweeted and